Okay, so we're going to talk about the landscape of pharmacy as it stands today, and some of the challenges and some of the controversies, and of course some of the solutions. And that's the run of show. But the bottom line is what we're going to talk about: what happens to the money. So you will hear from the manufacturers that the main justification of how much money is in the industry is because of how much they spend on research and development. So here's the best sort of comparison I've seen of that. So here's the billions of dollars that the pharmaceutical industry has spent on it. So I notice how I wrote that. Capital P, small pharma, which is a word that just describes the industry, because there's also their lobbying group, pharmaceutical, I forget what all they're in. It's the same word, but with a lot more capital letters embedded in it. So if you see the word pharma written with, I think, a capital P, capital H, and with less capitals, that's referring specifically to their lobbying organization. So I wrote this in lowercase, so you can. I just wanted to point out to you that the word pharma means two different things depending on how it's capitalized, interestingly. Anyway, there's what they spent on research and development. Where else does the money go? It goes to they're buying back their stocks and their dividends. So for most years, they spend more on their own shareholders than they do on research. And we're going to look at this from a few other ways too, but a lot of the money goes, into their industry. So there's their industry. I think Shannon's going to show you this chart in an hour or two. So you all got that, so we can move on. So it's complicated. It's designed, in my mind, for obfuscation. So let me unpack this in a little more detail, and let's look at what they call the beneficiary, or what I think most of us would call the patient. So I'm going to reconstruct that chart bit by bit in larger font so you can see kind of how the money flows, because I think it tells you a lot. The first, of course, is that we all pay premiums one way or another. We pay it, or our employer pays a premium to the insurance company. That's kind of straightforward. Or, as I said, our employer pays, some, most, none, or all of the premium, or other agencies might pay the insurance company. Your union might pay it, or what have you. Then the insurer typically doesn't feel that they have internally the skill set required to do this fairly sophisticated management of the pharmacy benefit within the overall health benefit. So they typically pay what are called pharmacy benefit managers, or PBMs. That's what it stands for. So these organizations that manage the pharmacy benefit, hence the name pharmacy benefit manager. And they pay the PBM in a variety of ways to manage the pharmacy benefit. And nowadays, most of those PBMs, if not all of them, are actually owned by the insurance companies or other large integrated organizations, and we will unpack that more. But essentially, the insurance company transfers money directly to the PBM. The patient, of course, has to pay a copay or co-insurance because it's America, and so they pay the copay or co-insurance to pharmacy, which, as you know, the higher, or the existence of that, and the higher that gets, the more likely patients are to not take their drugs. So, hooray for that. So they pay the pharmacy, and then the pharmacy purchases their drug and pays a wholesaler typically, and that's at a fee that's called the AWP, or average wholesale price. So you would think that there's some large database that collects what pharmacies pay wholesalers and rolls that up for every drug. And that's how it's sort of a database collection of a thing called the average wholesale price, or AWP. That is not how the AWP is calculated. It's a theoretical price that doesn't bear any direct connection to that. So, but yet it's called the average wholesale price, or the AWP, and that's a basis for a lot of calculations. The wholesaler purchases the drug typically directly from the manufacturer. It's what's called a wholesale acquisition cost, or a WAC. That's how these things are called, the WAC. And again, you would think that the wholesale acquisition cost was a database calculation, but it also is not. These are industry fabricated terms that may or may not have a connection to that, to the reality of what they are paying to acquire the drug. So the wholesaler pays the manufacturer, and then the manufacturer wants to get their drug placed onto a formulary. And the manufacturer may actually pay the PBM when the PBM is deciding which drugs to place on its formulary. There may actually be a formulary placement fee divorced from all the other fees. There may be a specific fee that they are paying just to get the drug placed. I guess, the PBM in getting your drug placed onto the formulary, in theory, gets people to purchase your drug, gets patients to take your drug, and increases the market share of that drug. And so, in many cases, the manufacturer will track its drug market share that's processed by that PBM. And if the PBM does persuade the manufacturer that they have increased the market share by its formulary placement and other tools, then indeed the PBM might be getting extra money just for having moved market share of the drug. And then the manufacturer, sort of divorced from those two payments, may just simply typically pays a rebate to the PBM. So for every drug that the manufacturer sells to the wholesaler who sells to the pharmacy that eventually gets to the patient. So the more the drug gets consumed, the manufacturer may give a fixed fee per drug to them. The PBM, in varying amounts, will give those rebates back to the insurance company. So that's a negotiated piece. That's part of the contract. And since they are now integrated in most cases, that's dependent on how much the insurance company wants to reveal or hide the what's happening to the rebates. But a variable amount of those rebates, sometimes all, sometimes just a part, will go back to the PBM. If it's not a PBM that is owned by that insurance company, then they will negotiate how much of the rebate goes back. It might be all of it, might be some of it, might be none of it. If there's no rebate, the less of a rebate that goes back to the insurance company, then the more the insurance company typically, or if there's less of a rebate retained by the PBM, then the PBM typically charges more of an administrative fee so that the PBM in its magical way stays whole. The insurance company justifies all of this by saying that this whole chart that I'm building for you, that all goes to get the healthcare to be less expensive to patients. So they, in some situations, will actually have a benefit design where the rebates are returned to the patients who took those drugs. Either all of the rebate or some of the rebate or a hidden amount of the rebate, or even if that doesn't directly go back as a rebate to the patients, the insurance companies, of course, justify the rebates by saying that they use that money to lower the premium that they charge to the patient because it's a revenue stream that they can use to offset the premiums. Hopefully, you recognize that when the insurance companies claim that this rebate is used to reduce premiums, that's a bunch of hooey. Insurance companies don't lower the premiums because they calculate the rebates. No, no, they charge the highest premiums that they can given the market in which they are selling their insurance product. So yes, if they don't have the rebates, they can charge a lower premium, but they're not going to because they want to charge what the market will bear. So, but the insurance companies claim that that the rebates help them lower premiums. PBM, then, so the pharmacy has dispensed a drug that the patient has only paid a copay for or co-insurance for. So the rest of the money for the drug comes from the PBM, which is paid for by the patient through their premiums to the insurance company, yada yada, and that's through what's called a maximum allowable cost or a MAC price. That's they call it MAC, and it's the MAC list. And the PBM owns the MAC list. The PBM gets to decide what it's going to pay the pharmacy. Pharmacies have precious little influence over the prices that are on the MAC list. The PBMs invest millions of dollars on software to have their MAC list be something that they can modify every day. The MAC list prices change daily, and it's based both on what they think the prices of the drug is, but also based on what they think the market will bear. And they make the MAC list price as low as they can until pharmacies actually start closing beyond what they can tolerate. So it's all sort of market negotiations. And then the PBM also typically pays the pharmacy a flat dispensing fee, $1, $5, whatever it is. It varies also a negotiated piece for every prescription. And then if the pharmacy has collected more of a copay than what the MAC list says, in most contracts, as far as we can tell, the PBM is able to claw back part of the MAC list or whatever they've reimbursed the pharmacy for. The PBM is able to claw this back, and pharmacies don't like that. And then the last piece is that manufacturers don't like the fact that this whole industry is designed to move market share blind to them, that it limits market share for drugs that are not on. And this whole industry is sort of not something that the manufacturers would like. They would rather get rid of it and just have it be a direct, unbridled market. And so manufacturers sometimes undermine that structure by helping patients with their copays, and then the pharmacy placement doesn't matter. So there's variation on all of this. You see why I said this is a system designed for obfuscation. It's designed to hide things. Pharmacy landscape has changed pretty significantly. You know, you can't read any of that, and it's kind of on purpose. The point is to show that on the left side, just 25 years ago, there were a whole bunch of companies, and by the right side, now there are very few. So these organizations, Cigna, CVS Health, and United Health Group, have grown by acquiring their competition. Those things all the way to the left were groups that typically competed with the things with each other, and little by little, these organizations have acquired them. That's called horizontal integration, where you acquire your competition, and that undermines market competition. And now we're left with these three big ones that control 80% of the market. And that means that they have far more negotiating power than when it was just this slew all the way to the left. So horizontal integration is really pretty rampant. We're nearly complete on how far that can go, and this has been unpacked in great depth by the FTC about a year ago. And then there's vertical integration, which is different but not unrelated. So here's the same. Here's the three PBMs that control the market, and they are owned by these large corporations today. I think all three of these were at one point, no, Optum wasn't, but these were largely independent organizations. Today, they are largely owned by these huge corporations, and these corporations also own health insurance companies. And that's, well, I'm going to keep going, but there's a reason that they're doing this. They typically now off, off, um, offshore a lot of their drug acquisition contracts. Ireland, I think, is where a lot of them go. And this allows them to do group purchasing, sometimes even together in ways that would be confounded here in the United States. And it certainly lets them sort of skirt a lot of the tax laws and other regulations. But these PBMs now typically work with their own group purchasing organizations to make it even more hard to track what's going on. Most of them own their own retail pharmacies. CVS obviously owns CVS. United Health, there isn't a chain of United Health retail pharmacies, but there's a whole bunch of little independent, smaller retail pharmacies that United Health owns, and Cigna doesn't seem to have any of them. They do all own their mail order pharmacy because those are really profitable industries. So they typically all own their own. In truth, you know, mail order are these large machines that have incredible accuracy and incredible efficiency. So pluses and minuses to it, but you know, you have to get your drug in the mail if you want to go through mail order. So that's a whole separate conversation, really. And then, as we're going to spend the back part of this discussion on, they all own their own specialty pharmacy. Specialty drugs are the really expensive, high-end, typically biologic drugs, and so they capture that part of the industry as well by dispensing their own. They often will label the drugs on their own, so the sort of pseudo generics. They'll acquire drugs and then put their own labels on them. And now they even own medical groups. And as you know, United is now the largest employer of physicians. So big vertical integration. Why would they do this? So unlike horizontal integration, this vertical integration means that they own cradle to grave in this industry. They own soup to nuts. Not only do they own their competition, but now they own, you know, nearly everything from manufacturing all the way to, you know, who prescribes the drug. So they control the dispensing and all of this stuff. And this didn't exist 20 years ago. This is a huge transformation of the landscape. And it means that when Congress, you know, there are laws saying that the medical loss ratio, I think we talked about that. You know what MLRs are. So you know, the insurance industry is obliged to have to spend 80 to 85% of their premium dollars on actual health care. Now they can hide it all through, they can hide their profits all throughout this industry by jacking up what they pay their own companies. So sort of what I alluded to a moment ago. Brand new information. I really recommend you have a look at this. Wendell Potter's group has just released last week this spectacular report looking at United Health Group specifically because they're the largest. So they spent a year going through this and look for the Sunlight report from Wendell Potter's group about United Health. About United Health, they own nearly three. This was 20 current as of 2024 filings, and speculation is that United is now north of 3,000 unique subsidiaries. And it's not just like healthcare groups. They own information services and they own marketing services and all kinds of other groups. So to get closer to my assignment about how formularies get there. So first, let's talk about how drugs get to the market. There's this thing that manufacturers have to submit to FDA called a new drug application, or an NDA, a new drug application. And so they submit that to FDA and then actually to FTC, this new drug, and then that starts the patent life. Once they submit the application for this, they have a 20-year patent. And then FDA, though, doesn't say you can sell the drug. The FDA requires that you prove that it's safe and effective and other things. So FDA requires actual clinical data. The manufacturer wants to get the patent submitted as quickly as they can so that nobody else can get the same patent. But they can't just release the drug onto the market because FDA requires research in humanoids about the drug. So FDA requires clinical data. And then when FDA is persuaded that the data is adequate, they approve the drug and launch the drug. And these studies are typically 500 people, 1,000 people. I think the largest clinical trial had about 10,000 people before the drug came to market. So large, expensive studies, 10,000 people. But then remember, millions of people start taking the drug. So guess what? After the drug comes to market, that's when we really start to learn about the side effects and the challenges of a drug. So there's this process that takes five to 15 years to get from submission to launch. So the actual sort of patent protected period for a drug is not 20 years on market. It's much shorter than that. And FDA makes that determination. Pharma, however, owns the FDA. Pharma owns the FDA. So during the HIV emergence as an issue in the early 80s, there were drugs for HIV that were taking years to get through FDA for approval, and HIV activists really were, well, they were dying, and they were desperate to get FDA to move more quickly. FDA didn't have the resources to move much more quickly, so Congress worked out this thing called PDUFA, the Prescription Drug User Fee Act, that came out of HIV activists, basically. And this meant that if a pharma company wanted to expedite a drug through FDA, they could pay a user fee and greatly expedite how long it took the drug to get through the market, through the approval process. You can imagine that this is the nose of the camel. So before this happened, it took 2 years to get through FDA, and as I was alluding to, then it shortened from more than 2 years to less than 10 months, or down to 6 months if they really want to. So before PDUFA, before the Prescription Drug User Fee Act, FDA was entirely funded by the public, and the most recent data I have, which is I think still actually current, is that pharma, again, small letters, pharma now funds 75% of FDA's Human Drug Division. And they claim it's a church-state separation, so that doesn't affect their decisions. So hooray for that guarantee. This bill, PDUFA, is renewed every 5 years. It expires every 5 years, and we are currently in what's called PDUFA 7, because we are in the 7th iteration, and it's going to expire in 2027. Up until this year, I was proposing that many of us should try to advocate to get rid of PDUFA and just go back to publicly funding, but that's a fool's errand in our current environment. It was difficult enough before, but so PDUFA, I'm pretty sure, is going to get renewed in 2027 and probably follow the trend of becoming increasingly egregious. And it's not just the FDA, but most of the course of drug development is funded by our tax dollars, right? So here's a study that looked at all of the drugs that were approved by FDA over this 9-year period. And of those drugs, almost all of them, 99.4% of them had some, if not total, funding on the research by FDA. And then if you limit that list of drugs, if you look at that full list of drugs, that means that FDA spent $187 billion. If you narrow that down to per drug, that means that NIH funding per approved drug was $52 million. FDA spent $52 million on every drug that ultimately got to market. If you look at the funding for the failed candidates as well as for the drugs that got approved, actually FDA funding rolling up what they spent in total works out to nearly $2 billion of FDA fund of NIH funding for new drugs. So we are paying for the research to get drugs to market. The insurance and the pharmaceutical industry, of course, claims that they pay for it all. So here's a study that looked at all of the drugs from a 10-year period from companies that had only one approved drug. So you can't get the interior data from drug companies about what they're spending on things in the way you want. So this is looking at the total cost of R&D for each of those companies per drug. And then if you add a bit, because not all the drugs get through their creation process, so give them some benefit of risk for that. Their total revenue after they spent $906 per drug, total revenue on average was more like nearly 7,000. So it's not an industry that's bashful from making money off of this. So we're paying twice, right? We're paying for the research, we're paying for the promulgation and the development of the drugs. And here's how that shows up as one example. So here's Ozempic. 900 in this study, it was a little shy of $1,000. I think now it's a little more than 1,000. But here's the list price of Ozempic. How is that compared to the rest of the world? You can go almost anywhere and spend like 10% of that to get Ozempic, the weight loss drug. So this drug was developed with NIH funding at the Bronx Veterans Center. We paid for the research. The rest of the world is benefiting from that, not having to do that. And indeed, we're the only ones getting screwed on the back end by the egregious pricing. Now, understand, pharma doesn't sell these drugs for $100 in Germany because they're nice to Germany. They sell it for $100 in Germany because Germany negotiates for that price. And pharma says, I can make a pretty good buck off of selling it in Germany for $100. So if we were to somehow normalize this data, that wouldn't really hurt pharma. They're selling it at those prices for a profit, or they wouldn't be selling it. They would have walked away from the deals. So we pay for the research, and insurance companies get to decide whether or not we can take the drug. So and they do that by creating what are called formularies, which is basically just a list of drugs, and by which insurance companies decide which drugs they will pay for. They decide how much the insurance company will pay for the drug, and if they can get the drug for that much, then they go with it. They decide how much the patient will have to pay for the drug. So they own this whole chain. That's sort of the vertical and horizontal integration I was showing you. There are a lot of formularies. When I worked at Express Scripts, we had one national formulary that we built and recommended, and we had one that was mainly a generic formulary. I guess we may have two or three national formularies that we proposed, but they represented less than half of the people in Express Scripts because most of the insurance companies and other groups created their own formularies. They didn't use ours. So that wasn't uncommon. Most insurance company has a huge number of formularies. There are today 66 PBMs. I just refreshed this data, and more than 1,100 health insurance companies. And each of these offer multiple formularies. So if you, when you're in practice, are trying to determine, which drug is going to be on formulary for your patient, if you don't have an electronic real-time answer to that question, you're not going to know. You're going to be the mouse going through the maze, bouncing into the wall and avoiding electric shocks because you have no way of really knowing. So let's spell out how formularies, at least in theory, are developed. In what they are actually in real life, in my past life. So the first is drugs are clumped together into clinical categories. So here's A, B, and C drugs that are clinically, let's say that these are three ACE inhibitors or what have you. Three, they're clumped together. And then you need to compare their relative clinical value. Is ramipril better than lisinopril, better than, so compare their relative clinical value. Consider the economics, of course, and then consider the market realities, which is something that I don't think most folks appreciate how important that is when these for-profit companies are making their determinations. So first, clump them together and then determine their clinical value. And you can usually rank them from higher to lower based on things. If they're equally good on all these metrics, but one drug has like three times as many drug interactions, well, that's a problem for that drug. It's harder to use that. So you can somewhat qualitatively, somewhat quantitatively rank these drugs by their relative clinical value. Statins, it's how much can it lower your LDL? So you can kind of do that. And then you want to look at their costs. So I'm making this cartoon simple, but in this cartoon, drug C is the most expensive and the lowest clinical value. And then in this drug, in this chart now, you're looking at the market share. So now drug C has the highest cost, the lowest clinical value, and it's frankly got a tiny market share. Drug B is more expensive than drug A, but has a much bigger market share, although it's not quite as good for some reasons. So then what do you do? Well, before you make your decisions, you also want to look if a patent is about to expire. Because if a patent is about to expire, say within 6 months, then the price of the drug will start to come down. For the first 6 months after a patent expires, the first generic drug against that brand drug enters the market, and for 6 months they have market exclusivity as a generic drug, and the price of the drug typically falls by about 10% during the first 6 months after the patent is expired. But after that 6 month period of exclusivity for the first generic mover, after that, then usually you see two, three, maybe six other generic manufacturers enter the marketplace for that drug, and then the price of the drug starts to fall pretty precipitously, sometimes by as much as 90%. So impending patent expiration means that if an insurance company is moving their business away from a drug that's about to lose market share or about to lose patent protection because they think it's, for all the reasons that you're thinking, because they think it's too expensive, it takes time to move market share. So before you decide to move against a drug, you want to consider how much longer does that drug have its patent protection. And then, of course, you want to look at rebates as an insurance company or as a PBM. So drug A is high clinical value, but it's offering and it has a limited market share, but it's offering a pretty juicy rebate. Drug B has all this market share, so it's not going to offer much of a rebate because it doesn't have to. It knows that if the PBM or the insurer doesn't offer drug B on their formulary, there's going to be a lot of angry people because they're all on drug B and they want drug B, and they've been marketing drug B, and if the PBM doesn't include drug B, then the PBM's clients, the insurance companies, are going to have to reconsider whether that's the PBM they want to stay in business with. So a large market share drug will typically offer a smaller rebate, and then drug C, of course, has nothing going for it, so they're going to offer this much larger rebate to help it start to acquire more market share. Well, who keeps the rebate? The PBM owns the rebate, and they may share it with the insurance company, they may share it with the patient, but it's PBM really interested in the rebates, and it's PBM that's really interested in how the formulary gets developed. So in theory, you would just draw a line, a 45-degree angle, if it were laid out this simple, and take the drug in the upper left-hand corner. You've got something of a rebate. It's got the highest clinical value. The highest clinical value should be all that you care about. But in reality, you also care about the market share piece in general. So you probably want to do that. You probably don't want to do drug C, but many PBMs will include drug C because of that juicy rebate that they get to retain. So what if drug C didn't have a rebate, but it had a huge market share? Well, guess what? It would probably find its way to your formulary, despite all that. Because if drug C is not added to the formulary, that means that the PBM doesn't have a contract with the manufacturer, which means that there's no rebate, so they're not happy about that, but there's also no discount, so that their client, the insurance company or the union or whomever, is going to have to pay full retail price if they don't add it to the formulary. So they do want to add it to the formulary if it's got this kind of market share. So market share can command formulary placement unless you have what's called a closed formulary. And we will get to that, I think, next. So formularies come in basically three flavors, an open formulary, a tiered formulary, or a closed formulary. And a tiered open formulary, I don't think anybody has this anymore, although that's what I grew up with. But an open formulary means that every drug on the market basically is something that the insurance company will pay for. And yes, that was how I grew up. Every drug was pretty much covered. And in general, if there is a copay, it'll be the same copay for any drug that's on the market. So the zero ability to move market share doesn't do that at all. Since it's just a wide open formulary, there's no negotiating. The pharmaceutical manufacturer sets the price. There's no rebate. There's no nothing. It's just, the way pharma wants it, actually. A tiered is really not a formulary. A tiered formulary is what you're probably the most familiar with, where you have, let's say, $10 for a generic drug, let's say $20 for a formulary brand, let's say $40 for a non-formulary brand, and something a lot more for a specialty drug. So these tiers, where drugs are clustered in these levels, and the drug tier determines the copay, as I was alluding to. So that's, in theory, to move market share, to influence patients to demand the less expensive drug, and to influence all of us to try to help our patients do that. It does move market share, although it's a pretty modest movement, but it does move market share. And there are some significant but relatively modest rebates compared to formulary structure number three, a closed formulary. And this is the drug covered or is the drug not covered? So there might be generics, there might be $10 generics, might be $20 brands, and that might be it. That might be it. If it's not a formulary brand, patient pays full retail for that price at the pharmacy. So the insurance company doesn't pay a penny of that. And the tiered system, if the patient pays, let's say, $40 for a non-formulary brand, a tier three drug, the patient pays $40, as I was alluding to. Well, it's a $200 drug. Who pays the 160? The insurance company or the PBM or essentially the employer or whomever. So in a tiered structure, the employer is on the hook whatever it is on the hook for paying for the additional costs. Whereas in a closed formulary, if it's not covered, if it's not on formulary, it's not paid for. If you want to have this, you need to have what business folks call a BATNA, or a best alternative to a negotiated agreement. There's a term you need to put in your pocket. So when you're talking to your MBA friends, if you can spell BATNA, you will impress them. The best alternative to a negotiated agreement, meaning you need to have a way to get away from them if they're not going to negotiate with you. A closed formulary really should include exception criteria. And we always recommended exception criteria, but not every employer accepted those. But there should, because you can't make a formulary that's one size really fits all. This, of course, is the most potent way. Typically, it has the largest rebates because it's the most potent approach. So that's sort of a high-level look of how drugs get to market. What about generics? Well, generic drugs don't go through that process of 20 years and they don't go through any of that. Instead, thanks to the Hatch-Waxman in the early 1980s, there's a faster pathway for generic drugs. A generic drug doesn't have to recreate, a generic manufacturer doesn't have to recreate the clinical studies, which take years and years. All that the generic drugs have to do is be able to demonstrate that the same pharmacokinetics apply, the same pharmacology applies, that it's chemically identical to the brand drug, and that when they give a person the drug, it's got the same blood levels over the same structure of time that it's measured for. So they need to be able to demonstrate pharmacologic equivalence to the brand drug. They don't have to repeat the clinical tests, but if they can demonstrate pharmacologic equivalence, then they can get FDA to release them to the market. Pharma doesn't like that. I'm going to skip that just because I'm blathering too much. But here's an example of a drug, Brisdell, which is on the market for 7.5 milligrams to treat menopause symptoms. And it costs $233 a month. So a drug to treat menopause symptoms, hooray. It's the only FDA-approved drug to treat menopause symptoms. So Brisdell, $233 a month. Brisdell is also now available as a generic at 7.5 milligrams. And if you get that, it's just $63 a month. Have any of you heard of Brisdell? Ever heard of this drug? Good. Brisdell is paroxetine. You've probably heard of paroxetine. Paxil. Paroxetine came to market, I don't know, 30 years ago as Paxil, as an antidepressant, an SSRI, much like Zoloft or there's a bunch of these, Prozac. There's a whole group of these that are very, very similar. So paroxetine is one of them. And it's available not in 7.5 milligrams, because when Paxil was on the market as a brand antidepressant, it was on the market in 5, 10, 20, and 40 milligram doses. So the generic had to show chemical or pharmacologic and chemical equivalence. So the generic Paxils or generic paroxetine is not available in 7.5 milligrams. It's available as 10 milligrams, and it's only $20 a month. I submit to you that the manufacturers of Brisdell anticipated that this was going to come up, and so that's why they made Brisdell 7.5 milligrams. There are no head-to-head studies comparing paroxetine for hot flashes from 7.5 versus 10 milligrams, and there is like no reason in the world to think that one is more effective than the other. But if I write for Brisdell and I write may not substitute, well, then the patient just has to get the brand. If I write may substitute, which is sort of default on prescription pads and filings now, then the pharmacist can dispense generic Brisdell for $63 instead of $233. But the pharmacist cannot dispense paroxetine, generic paroxetine 10 milligrams, because it's not the same thing that I wrote. So the pharmacist has to reach out to you, and they don't like to do that. That's a pain in the butt. So it's a pretty clever gambit. So that's one way that pharma manages to undermine generic drugs. So they do that by dose mismatch. That's one of their strategies. They also do it by having an inert ingredient. So asthma inhalers before your time were pretty cheap. You could get them generic. They were $5, $10 for any asthma inhaler pretty much. They were on everybody's generic lists. They were great. And then when EPA wisely said we need to get all the PCBs out of the environment, the asthma inhalers all lost their PCBs and had to switch to different propellants, and they got reformulated. Same darn drug, same pharmacologics, same everything, except a different inert ingredient. And the price went from, $20 to hundreds of dollars. And we're still in recovery mode. Asthma inhalers now are still, several hundreds of dollars. Good luck finding one of the ones that's actually cheap. So changing inert ingredients is another way to undermine it. Lyrica, when it came to market, and gabapentin when it these are both anticonvulsants, as you know, which don't really work very well for seizure disorders. Instead, they're largely used for something else that they're highly ineffective for, which is neurogenic pain. That's how they're usually prescribed now, even though they're really crummy at that. But neurogenic pain is really hard to treat, so we give people things that are marginally effective because they're desperate and we want to do something. I'm being ironic. That's not a good strategy. These drugs are not terribly effective for this, but yet they're widely prescribed for neurogenic pain. So Neurontin was the first of these drugs, and Neurontin's patent expired, years ago at this point, and so that now you don't prescribe Neurontin. You can prescribe generic Neurontin, which is gabapentin, and right around the time that Neurontin's patent expired, Pfizer released a new drug, son of Neurontin, called Lyrica, and promoted that as a brand drug for years, and said, "Hey, this is more effective and based on nothing than Neurontin." And what is Lyrica? Lyrica is pregabalin. So Lyrica actually is pharmacologically very inactive. It's got some effectiveness, but very low until you metabolize it into gabapentin. So it's the same damn thing, but it gave with no evidence of being more effective, but it gave the manufacturer a chance to advertise a brand protected drug and keep its brand protected market niche. And then one of my favorites, for reasons I'll spare you for time, but Bidil is just the combination of two generic drugs. So, there isn't, I don't think, a generic version of these two drugs put together for heart failure. But these combination pills are nice, it reduces the pill burden, but they're another way to kind of protect the patent, and then in peds as well. So takes us to biologics, um, which is really where the game is today. These are large, these are not sort of made in a test tube. These are mixing some chemicals together. These are large biologic reactors, which hugely complicated molecules, big gloppy things produced typically in, I believe it's Chinese hamster ovary cells, that are hamster ovaries that grow I don't know, that's probably not that anymore, but they're large molecules that are grown in biologic systems that are these really complicated structures. They're not very widely used because they have very specialty niches. So most people don't take one of these, but they're outrageously expensive. The most current data I saw was they're nearly $5,000 per pill. But because they're not just sort of a chemical formula, they're these biologically produced things, you can't do a chemically identical thing. You can't. There's the complication. You can't do that. So we originally were calling these biologic knockoffs. We were calling them biogenerics, and that's really not appropriate because they're not the word generic is not the same. These are not biologically, they're not identical, so they're not biogenerics. That was a misnomer early in the industry. And now you'll see the phrase biosimilars. And that's why the word biosimilar is in the vernacular in the industry, because they're similar, biologically similar. And we depend on that the same way we depend on generics in the oral solid industry. So, of course, and the same thing in the oral solid stuff, pharma doesn't like this. So, one of the ways that they avoid biologic and biosimilar entry in the United States is by having these huge array of patents. So, these drugs have far more patents in the United States than they do in the European Union, where that game is simply not tolerated. Here, a lot of the patents for these drugs is specifically so that they have this more complicated patent protection. And so these drugs that were released previously in the European Union as a biosimilar, the entry here because of these complicated patent rules, 5, 10, or more years. So this game of complexification of the patents for these drugs is very effective at protecting their industry. But these are coming, I sort of alluded to it, these are coming. So we're seeing some growth, but over the next 5 years, we're going to see more of these complex patents expire. We're going to see more competition, and the drugs are going to be more and more on market. So the biosimilar industry is starting a rapid growth phase. For these are the most common conditions that you see them in use. So expensive chronic diseases. They don't like to treat short-term acute things because they like you to be on them for a long time. So there are strategies. There's this eternal patents that we were talking about, and they're often filed. They can continue to file patents, and this extends their solution for years. And the only way to really fix this is to kind of revise the patent structure in the United States. So one little example, this drug, for macular degeneration, the FDA approved the drug in 2011. It had billions of dollars in sales. But it had a whole bunch of patents even after FDA approval. And because of these things, despite that 5 to 10 year patent protection I should turn that up, I'm sorry. Despite that I alluded to before, this drug is protected for nearly 30 years, despite the patent process. So biosimilars are trying to fight back, and indeed, Gilead tried to introduce this for this year. Gilead sued drug manufacturers, or biosimilars were trying to introduce this stuff, and Gilead sued the manufacturers and wound up just sort of tying them up in court. And now biosimilars should have been here this year, but we're not going to see biosimilars for several years because of that strategy. So you probably know the Inflation Reduction Act finally let Medicare negotiate the prices of drugs. And so the Inflation Reduction Act introduced a maximum what we spend on insulin. It started producing a maximum out of pocket for Part D, and it, this year lowered the maximum out of pocket for Part D quite a bit. So hooray for that. It also created next year the ability for Medicare to finally start negotiating the prices of drugs in Part D and more the following year, and then even more going forward every year that it takes place, and then eventually to start negotiating drug prices in Part B. And so, yeah, this is a growing thing emerged by the Inflation Reduction Act, which is being undermined by the 2025 Budget Reconciliation Act. Hooray for that. No, not hooray for that. So the Budget Reconciliation Act has expanded the protection, the exemptions for orphan drugs. I'm not going to unpack that in much detail, but there was a protection for orphan drugs from having their price negotiated, and that's been expanded by the Budget Reconciliation Bill. And CBO projects that this is going to significantly, materially reduce the benefit of price negotiations from the bill. So, price negotiations work. So here's the Medicare price that's being anticipated for these drugs. So significantly less than the current list price, but nowhere near the value or the negotiating power in comparable countries. So, hooray that Medicare can negotiate the prices of drugs, but nowhere near the power because Medicare drug negotiation is just for the people in Medicare Part D. It's not for the other hundreds of millions of Americans, so they don't have the negotiating power that these other countries have. So here we have a very fragmented insurance industry. Most other wealthy nations, there's one national formulary that they can negotiate for. Here we cannot use the Inflation Reduction Act explicitly said that Medicare can't use international prices as the basis for how we come up with our prices. We are precluded from that. Whereas in other wealthy nations, they talk to each other. That's part of how they figure out, well, you sold it to France for so much, we want a price like, so they can do that. And here we actually can't use international reference pricing. We have these wealth of laws that are screwing up that take advantage of the patents and such that we were alluding to. And in most other wealthy nations, they have laws that make it far easier for biosimilars to enter the market, as I showed you, and for various pricing structures. So what we're proposing, PNHP hat back on, what we're proposing is that the nation can address this most effectively by introducing one single national formulary for the country. Understand, you could do a national pharmacy insurance strategy, one national PBM approach, absent a national health insurance approach. You could do just the pharmacy piece of Medicare for all. You could do that without doing Medicare for all. So better to do it with Medicare for all, but you could establish a single national formulary that included all medically necessary drugs and exceptions for those for whom it's really not possible. You could do this in a way that eliminates copays and other cost sharing, and you could do this getting real negotiating power. You could make this with real negotiating power, and then we could match that right-hand column that I showed you. The law, actually, current law says that if a drug is funded, you don't know if you know this, but Hatch-Waxman, when they passed this pathway to generic drugs, also said that if a drug is on the market, in a way, and it's been funded by NIH, which is almost every drug, as you saw, if a drug is on market and NIH has funded it, the funding organization has the right to ask FTC to break the patent of a drug that's on the market in a way that doesn't serve the public good. So current law enables NIH to request FTC to break the patent on drugs that are not serving the public good, which is why NIH funded the research. And primarily that means price gouging. NIH has tried that, I believe, 6 times, and FTC has invariably said, oh, we don't think price is actually relevant to the question of whether it's serving the public good. But the point is, an FTC that decided to do that is currently empowered to really help with undermining price gouging of this. And then you need a BATNA, of course. You need a BATNA, best alternative to a negotiated agreement. And indeed, that's in current law. Current law is that you could break the patent, and if no generic manufacturer wants to step up and produce the drug at an affordable price, that that we could actually authorize the public production of the drug, truly a socialized solution, which I don't think most of us want to see, but you could actually, current law allows authorization of public production of a drug. And indeed, the threat of that was pretty effective at times, although it's never actually happened or come to pass. So we have strategies. We have a way forward here. And I squeaked it in my time assignment. So we have a few minutes. Thoughts, questions, concerns, a lot of information. Yes, Anana.
Um, when you're showing us drug prices, is that the price for like 1 month or one dose, or is it usually like the yearly cost of the drug price?
Most of those were dose.
Wow, okay.
Yeah. Those $1,000 prices, that's a
Yeah,
dose.
one was like 20K and I was
Yeah,
that's crazy.
it's an obscenity.
Okay.
It's an obscenity. So these are our last few minutes together before you scatter off to the hinterlands. I've talked about a lot of stuff with you guys in the last few weeks. So I would say for the next few minutes, any of those topics are on the table if there's something you want to unpack or complain about or disagree with or
I'll just
if
say,
not.
I just
Hmm?
want to thank you. I want to thank you a lot for all of the presentations that you've given us. They always have been so informative, and I think they've shaped a large part of my experience in this internship, eh, like in being really positive. And I take a lot, and even in my final presentation, I find myself going back to your presentation. So I'm very appreciative.
That's great. I'm delighted to hear that. I have one ask of you all, which is to stay engaged with PNHP. This is why we do this program, is for you to, if you hear all the stuff for this season, this whole session, the whole internship, and decide you completely disagree with this stuff, and you're inclined to go join the George Mason University or something, you want to head down that road, more power to you. That's great. Do follow your heart and your belief system. I'm not telling you to, but if you think this stuff all makes sense, and if you think this is stuff that you agree with, well, then embed activism, embed PNHP in who you are and what you do, and find a way to, go to our annual meetings, find a way to pay dues. That's really all we can, do that. When you get through with being a student, find a way to keep this as a part of who you are, and that comes in small, medium, and large, as we talked about. You can just do little bits. You don't have to take on the whole universe. Just every little bit that you can do helps. Come to our annual meetings every year. Make a point to do that. To get rejuvenated and refreshed by knowing that you're not the only one who thinks the stuff is important and is solvable and thinks there's a way forward and wants to help move the ball down the field. All right, great. Hope to see you in DC at the annual meeting. Come up and say hello to me if you're there.